Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 39 of the OBGYN podcast. This is the monthly checkup for August 2018, and with me today I have Jillian Kurtz and Sarah Kim. Welcome.
Thank you.
Thank you for having us.
So I think that we have three very thought-provoking and certainly less dense topics than the last time the two of you were on. So I'm excited to get into these and not have to destroy our brain thinking about cell-free DNA profiles and things like that and mice studies. So we'll dive right in. The first one is probably the most fraught to talk about, but I think it's important. And that has to do with sexism in medicine, and particularly in OBGYN. Now, this topic comes from a paper that has been accepted for publication at AJOG entitled Sexism in Obstetrics and Gynecology, Not Just a Quote-Unquote Women's Issue, which I don't know that I like that title, but that's a different subject. This is by Francine Hughes and Peter Bernstein from NYU, and they really start to try to tackle the inherent sexism in medicine and how it relates to OBGYN because, as the authors note, we uniquely for medical fields are more than 50% women. We're about 60% women at the moment. And so we probably relate to this subject differently than most of the other fields, maybe in a positive way, maybe in a negative way. So before I kind of dive into what they're saying as the only man in this conversation, what are you guys' thoughts about this topic? Something that you think that we need to be talking about? I don't know if you have any experiences, you're comfortable talking about them. Like, where does this topic sit for you?
I think it's a very relevant topic, and as someone who currently is interviewing right now for a fellowship as well, I definitely see the shift in that a lot of the applicants are definitely females. And the paper also mentions that up to 80% of residents now who are matching into OBGYN residency are female. Yet you do see that a lot of my interviewers, a lot of the people who are kind of in the higher ups are definitely predominantly males, which is not to say it's a bad thing, but it's, it's in a field where it's now becoming more and more females. It's definitely something that I'm noticing more, especially now that I'm interviewing more as to who are the people on the other side of the table who are in the department chairs or division chairs, who are kind of the oncologists who are interviewing me. I think it's because I've definitely noticed that a little bit more, being on the interview trail versus when I think I was as on the resident interview trail.
Well, as you touched on, Joe, this is a larger issue in society in general, so it's kind of a nice opportunity to talk about it in relation to our specific field and maybe talk about what we can do to make things better in the future.
Yeah, I mean, so I guess we'll just dive into some of the topics that they brought up. The first thing they talk about, and I think got to be the easiest thing to fix, although apparently it's not, is pay disparity. And of course, this is not just a medicine issue, it's an entire world issue in every single field, which has been well documented and especially brought to light over the last 2 years with the Me Too movement. But they found in the United States that the pay disparity is about $36,000 between men and women who have the same rank, same credentials, which is, it's huge. The average salary for an academic is about $260 in the U.S. and the Northeast at least. So $36,000 is more than 10% difference. So that's a huge difference between men and women. And I will tell you that one of the things that I think that we can do about pay disparity is be open. I am a very strong advocate. There's no reason why, if we all work in the same place, we can't talk about how much money we make. Like, we're all doing the same job. Why don't we just share information? And if we all tell each other what we make, then this disparity goes away because it's open. And as soon as it's in the open, people won't tolerate it anymore. It's when it's hidden that we have an issue. So I think this has got to be the easiest to fix if we all just are open and honest about what we make with each other.
I agree. There's this sort of culture of secrecy, if nobody kind of divulges exactly how much they were offered. And you're also discouraged from divulging how much you were offered by the people who you're establishing a contract with, which is really unfortunate. Mm-hmm. So if there was that sort of, financial transparency, you'd really hold everybody accountable. Mm-hmm. I thought that's a great idea.
Yeah, I definitely think it's a culture thing. I didn't realize it until a lot of my friends who kind of grew up in Korea and kind of came here, they were openly asking people like how much they're making, and they were shocked to see that a lot of people in the States feel very private about their financials and how much they're making. And so it might be a cultural thing. Whereas apparently I asked him like, why are you so shocked? In Korea, it's very common practice when you meet someone to be like, oh yeah, how much do you make? And it's not considered offensive. It's just part of the conversation, like part of the introductions. And I think it might be a shift in how the way we think is that, maybe one way to kind of really close the pay gap is maybe there should be transparency and not take it as an offense. It's not to kind of probe you as to how much you're making, but it's more just kind of being transparent about that. And I think part of it is definitely a cultural perspective on how people could take that question.
Yeah, I mean, one of the things I did at Stony Brook when I came back is I set up a pay scale that I publish, so everyone in my division can calculate their own salary. Now, there's a little wiggle room for people who do extra things. They get involved in education or whatever it may be. But your base salary, you can just look at this table and figure it out. And so I'm not telling everyone what everyone else makes, but you could just look at it and figure it out. It's not hard.
Or I was going to say, if you had everybody like on an RVU-based system, so if the more productive you are, the more money you make, although that gets more challenging in an academic setting when, you're not necessarily producing profit for the hospital. Right,
RVUs.
exactly.
Right. Yeah. That is certainly the issue in academics. I mean, we could have an entire podcast about how we, compensate ourselves. But certainly in academics, there's a lot of things that are valuable that aren't necessarily clinically productive. And of course, we pay ourselves with clinical dollars, but that is not our end-all, be-all mission. It really is research and education and, doing studies to improve women's health that don't necessarily make us any money. So it is challenging. And that's why that's why academics make less money than private practice people. It's just, that's how it goes, right? Because our primary goal is not making money. But we found that with that transparency and that people are at least less upset about it. They can look at it and figure it out, which is nice. And that's something, we've only started doing it, so we'll see how it goes over the next few years as we adjust the formula. But I'm excited that people seem to be excited about it. And they started it. The people who work there started telling each other what they make before I even got there. So that was open and honesty, I think, is the way to do it. And we just got to band together, men and women. It's mostly women because most of the field is women, but we just got to band together and talk about it and not be afraid that, someone's going to be branded as not a good negotiator. I don't know. Anyway. So the next part of it they get into is leadership. And this is where I really have some strong feelings. And they are, I don't know, we'll get into it. So 60% of women in OBGYN are women. We talked about that already. And only 22% of leadership is women. So that is a huge disconnect between the general body of employees and the leadership. And I think there's a few things that go into that. The paper talks about a few of them. Honestly, the paper kind of gets more into the different kinds of sexism and how that permeates society, which I think are important. But I think they miss a little bit of what I think are the core issues in leadership. Really what I find for leadership is who gets promoted, how do you get promoted, how do you get recognized for being promoted, and then this factor that people tend to recognize and promote people like themselves. Right? And that's just, I think, human nature, right? So let's start with, how do you get promoted? Now we're talking about academic medicine, obviously, here. In private practice, it's just about how much money you bring in and how well you get along with your partners. So in academics, for most people, getting promoted is about research, it's about education, it's about service to the hospital or university, taking on projects, doing well. And of course, those things all have to be recognized and appreciated by your chairman or whoever your boss is. So that's part of it. But also, usually you don't get more time to do those things, right? You still have to do all your clinical work. And so there's an expectation that if you are going to do this extra, it's going to be during time outside of work. So at nights and weekends or early in the morning or whatever it may be. And I think that part of it right there gets to the core of why men tend to get promoted faster than women. And I'll stop there for a second. I want to get your thoughts, and then I'll continue and probably get myself in some hot water. But go ahead.
Sorry, no, I think that you make up a good point, and it sort of touches on a topic that you guys discussed a couple months ago at the monthly check-in regarding family leave during OBGYN residencies, and how women were, essentially discouraged from taking the full amount of leave that everybody thought was best in the best interest of the family. So it touches on this challenge that women have, this like sort of innate pressure on themselves to be a mother and a wife, but also be a career woman and an OBGYN. And how do you remedy that? How do you be both of those things?
Yeah, it's like the balance of kind of, we talk about just like work-life balance. And I think there is societal expectation a lot of times where the woman should be kind of taking care of the kids. And biologically, women are the ones who are going to be carrying the baby and being pregnant and delivering. You need that time off. And I think the expectation is that women are kind of more motherly, matronly. So I actually talked to an attending, and she was able to be a chair, who said basically she gave up. She's married, but she doesn't have any children, because she said, I felt the pressure that if I have any kids, I'm going to have to give up my professional life. And I think that's a pressure that a lot of women feel, whether they place it on themselves or place on by the work environment. But it is definitely a pressure that you feel like you have. Those are two competing things, where you have this work with career professionalism and development, and then this home life of having kids and having family.
Yeah, that's really sad to me that she felt that way, but she also is smart enough to recognize the inherent societal structure, right? Like, there is certainly this is where I probably get in trouble, but there is certainly a biological tendency for women to be more involved in rearing children than men. Now, it doesn't have to be that way, but even if you have men and women who are equally committed to raising children, I still feel like you're going to end up with women doing 60% and men doing 40%. That's just my feeling, and I could be wrong about that, but that's how I feel. I do think that we're all educated, and so we have a lot of educated men and women, and women in OBGYN and doctors in general obviously are very highly educated, tend to marry educated men, and I feel like we are more likely to participate actively in the raising of our children, as opposed to saying, well, you had the kids, you raised them, I'm going to go to work, and then after I go to work, I'm going to do my other job, and then I'm going to go to the bar after that, and I'll see you on Saturday morning, right? So I don't think that really happens, at least not as much. But that being said, I had a point here. I'm gonna come back and I'm gonna find it.
I mean, do you think that's, we're talking about how women place that pressure on themselves too, but is that how, like, when people are, and I think that kind of goes to the paper too, like when people are thinking about, this position needs to be filled, someone needs to be promoted, are women being kind of bypassed, being like, well, they have no time, they're probably more devoted to family life than, is that like an assumption that a lot of people make? Like, I'm sure she doesn't want to do it because she's more devoted to her kids. Like, this is too much on her plate.
I think I think people definitely feel that way. I think women feel that way about other women, and I think men feel that way about women. The other part of it is you are, in a sense, always interviewing for your next job. Right? You're in your current job. The work that you're doing then gets you your next job. That's how it goes, right? And so if you go on maternity leave and say you take 12 weeks, which is nice, you get that. We should encourage that. And then you come back, even though you are no less committed to the job than, say, a male who is not going to take 12 weeks of maternity leave because they're literally not having a baby, right? And they don't have to breastfeed, right? Even if you're both equally committed, the man now has a 3-month lead on you, right? Even if you're all equal. And so then I'm a leader and I'm going to choose my next person for whatever this is. And I have someone who's 3 months ahead of the next person. Well, who do I choose? And so that's where I struggle with this, because part of it is choosing the best person that you have, but then combating that and saying, they've done these studies, right? The more women you have involved in things up to a certain point, like men, actually we talked about it in the last monthly checkup in the OR, right? The more balanced you have your genders, the better everyone does. right? So, but how do we combat that? Do you take someone and say, I'm going to choose this woman who actually has slightly less credentials than you, but because she had 3 babies, and so, but I think you're both equally qualified, but I'm going to take her because she's a woman, and so you start getting into that, and it gets complicated on that end too. So, I mean, obviously, there's no easy answer here, but it's something that I really struggle with.
I was talking to my husband about this article, and he's a huge sports fanatic. So he was telling me about the NFL, like what they do to try and increase diversity in the NFL, and how they have something called the Rooney Rule, where every time they hire a coach or some sort of like senior high level position, they necessarily have to interview an ethnic minority as a potential candidate. So I was like, oh, that's not a bad idea. For every, program director position or department chair, they necessarily have to interview a female. And you're right, maybe she doesn't have the same credentials, and maybe they choose to take her, but at least they're considering a female for a higher up position.
Yeah, I want to be clear that I actually believe that we need to, look at those 2 candidates and more often choose the woman in that, and not just go based on what's on paper. I mean, of course, it depends on who your 2 candidates are, but I just want to make clear that I'm not advocating that we should never hire a woman who's have the same.
No, but the article also touched on something about like maybe we need to establish a mentorship program. Like a lot of the men in these higher up leadership positions, they didn't get there on their own. They had a mentor and a leader to kind of like help build them up to where they are. So maybe we can encourage our women to be mentees and get there.
That's certainly a big thing that's going on right now in ACOG, is trying to find middle to older career women to mentor younger women, especially in academics. That's huge right now, and I think it's got to be part of the solution.
I don't think it necessarily has to be only females, though. I think sometimes in this debate, it's easy to get into like a men versus women thing, and I think like a man in a leadership position would be able to also mentor, a young woman and get her to where he is as well.
I think that's a good point. You're absolutely right. I certainly, in talking about this and getting myself worked up about it, I certainly ended up coming down on that side of it just by default. And I think that really speaks to some of that inherent, I won't call that sexism, but some of that inherent gender issues that we have as a society. But I do think, to go back to it, I think, there is, I think, a cutoff or a threshold when we get enough women in leadership that the tide will change. Because, like I said, I think, men are probably more likely to hire men. Women, I would think, are more likely to hire women, although there's also sexism that women kind of, inherent sexism, women absorb as well. But I think once we get to a certain point, whether it's 30% or 40%, I think hopefully that this tide will change and we'll end up with more equality. Although at the same time, 80% of women 80% of residents are women now. Eventually, there's going to be no choice to choose anyone other than women anyway.
Well, I mean, they kind of touched on that a little bit, and they said that, we can't just wait it out and wait for these women to start assuming those roles, because that doesn't seem to be, even though we have women in leadership roles at a slightly higher percentage than the rest of the field, it definitely doesn't mimic, it isn't where it should be.
Yeah, agreed. So just to finish up on their paper, what are the things that they said that we can do? So the first thing is that we can learn about the problems of unconscious bias and gender disparity and examine how to participate in it. And this gets into a lot of, anyone who's worked in a corporate organization, you get all this gender sensitivity training or sensitivity training in general, and you have to go to, actually we do it in medicine too, where we have to talk about both gender and ethnic and cultural sensitivity as far as dealing with our patients. And this is sort of the same thing. And those things can be kind of torture to go to, but they're so important just to plant that seed in your brain to say, oh, maybe I should think about this when I'm making a decision about X, Y, or Z. So I think that's a good suggestion. The second one was create open forums to listen to others' perspectives on issues of disparity. And I think that goes back to what we were saying earlier, just about having open and honest dialogues with each other about a whole host of things, from salary all the way to how we get promoted to how we get recognized. So I think that's good. And the last one is encourage mentorship of women. That's what you were saying, and advocate to increase their visibility in the broader community, which goes from ACOG to SASCOG to any of the professional organizations that we belong to. And again, the more women we have in things, the more equal we are. I think that momentum eventually turns into a tide, I hope. So I will say the last thing, this is a personal thing. In my department right now, most of the leadership is men. And that bothers me a lot. It bothers me from thinking about how I got where I am. Did I get where I am because I'm good at what I do, or did I get where I am partly because I'm a man and not a woman? And that really bothers me. So, and also, how do I help the women who, and mostly women who work for me, how do I help them take that next step up the leadership chain into something? How do I identify possible positions for them where they can take something and excel at it? And I've been spending a lot of time thinking about that over the last couple months, and this paper really drove it home for me. But it certainly got into my brain, this paper, and has been wiggling around. So I can thank Dr. Hughes and Bernstein for that.
Yeah, I mean, that's a good point. I think, I think they would appreciate your encouragement, because a sense that, sometimes like I feel sometimes too, is if I see, it may feel like it's an unattainable goal. Like seeing that it's only dominated by men, so women may I think part of it is women themselves saying, well, it's not achievable, so why even try and like do all these things? It's going to go unnoticed. So like having that encouragement, knowing that, the work is recognized and that it is possible. I think that's also tied in like how to encourage women to kind of take a step back and be like, it's not something that's unattainable. It is something that you could go, because, historically, even the paper mentions that even if women try to maneuver like grants and get renewals, a lot of times they're overlooked. And so, if all you get is rejections, then you may kind of reach eventually that what's the point of me even trying, because I'm just going to get overlooked anyway. And I think it's good to have that kind of encouragement.
Absolutely. There was it was a startup, it was a few months ago, where the two women, and they gave themselves male names and made these male personalities, and they emailed all these investors, and they got back all these things. And then for the previous 3 years, they were doing it as themselves, and no one was getting back to them at all. So, I mean, it's there. It's I don't know. You want to say it's not there, or at least, I'd love to believe that it's not there. But all the evidence points to the fact that it is. So it's just, once you have recognized the problem, you can begin to address it, right? So I think this paper is another good step in saying there's a problem here. Let's all recognize it and try to address it together. So kudos to them. All right, so the next two topics I think are a little less fraught. So the next one is actually from Pediatric Journal, from Pediatrics in August 2018, and it is entitled HIV and Syphilis Screening Among Adolescents Diagnosed with PID. It's from George Washington University. And what they did is a very simple paper. I'm not going to go through the whole thing, but the CDC recommends that anybody who's diagnosed with PID, and that's actually what I want to talk about, is how we diagnose PID, but how women diagnosed with PID, I think it's age 12 to 21, and whether they at the same time got HIV and syphilis. And the CDC definitely recommends HIV and sort of recommends the same for syphilis. And they found that over the course of the 6-year study, only 20% of these adolescent women were actually screened for HIV, and it was slightly higher for syphilis. And they did notice, however, over that 6 years, there was a trend increase from 16 to 26%. So we were getting better, but still pretty abysmal. But it did get me start to think about what we do for PID. Now, I don't actually usually think about syphilis for when I diagnose or treat for PID. HIV, I usually think about. Our ER is pretty good at sending that, so it's not something that we really need to think about ourselves. But it got me thinking about how we diagnose PID, how we treat these women, and what our follow-up is. And I did an episode on this, I don't know, feels like 2 years ago, but it was a while ago now, where we talked about how hard it is to diagnose PID. So anyway, before I get into all that, what did you guys experience with diagnosing PID? Do you often think about screening for HIV and syphilis? What do you guys think?
Well, our climate at our hospital is We pretty much do a full STI panel if somebody presents and we're diagnosing them with PID, because as the CDC said, even though it's not directly recommended, anybody who engages in high-risk sexual behavior should be screened for all sort of sexually transmitted infections. So we generally run a full STI panel on anybody, especially if they're admitted for it. What about you guys at Stony Brook?
I definitely don't. HIV, I think routinely, and just because one of those reflexively, a lot of times in ED, they kind of get tested for it. Although I do kind of agree with the paper in the sense that in some of the pediatric population who are really, really, like kind of more on the younger side, maybe like 12, 13, 14, it might not always be performed just due to like consenting processes. But syphilis, rarely. I don't think, syphilis is definitely tested. Occasionally when people come to clinic and they want like a full STI panel, it definitely gets, that's part of one of the ways we screen them. But if someone just comes in and we're kind of diagnosing with gonorrhea, chlamydia, swab, and they're kind of concerned about that, that's usually what we do. If they're admitted, they do get a little bit more, intensive full workup of having HIV and usually sometimes syphilis, but definitely if they're just kind of coming for an ED visit and it's an outpatient management, HIV, I would say 99% of the time, syphilis, definitely not.
Yeah, that's kind of how I felt about it too. I think, so what this got me thinking about this as we diagnose PID is that since there is no gold standard for diagnosing PID, we don't have a test that we can look at and say, these women have it, and then we can compare all their other tests against that test, that we end up with what the CDC recommends, which is basically just if anybody shows up and they have pelvic pain and they have no other cause of it, and they're a woman, treat them as if they have PID. Because the treatment is relatively benign, but the consequences of not treating can be severe. Anyway, so it got me back thinking about this whole PID business and how bad we are at really given understanding what the pathophysiology is. And I'd be interested to look at the rate of HIV or syphilis by age group. We do know that the younger you are, the more likely you are to have PID that is caused by gonorrhea, chlamydia, or at least associated with gonorrhea, chlamydia. Who knows what causes PID? And then certainly as you get older into your 30s, 40s, and I'll say 50s, it's more likely to not be gonorrhea, chlamydia, to be other bacteria. And that brings me onto a tangent. Recently, we've had a whole bunch of 57-year-old women who were transported to Stony Brook with quote-unquote a TOA. And every time we're like, they have diverticulitis. Like, I understand that the colon happens to be next to the ovary. And so therefore, when there's an abscess in it, it tends to be a left-sided quote-unquote TOA, but that's not gynecology. Yeah. But in any case, just since it's been a rash of it recently. But anyway, I don't know. What are your thoughts about diagnosing? Like, are you overly inclusive? Do you really try to get CMT or to get uterine tenderness? I don't know. What do you guys feel about just diagnosing PID?
Often, I think you sort of touch on this a little bit. It's oftentimes a pretty soft call. They might have a white count, they might have a fever. CMT, the ER sometimes will tell me they have CMT, and I go and I'm like, I don't buy that. That's not CMT. So that's such a...
Like every time.
It's like you just did an aggressive pelvic exam.
But I think oftentimes we'll err on the side of, admitting them for IV antibiotics just to cool them off and see if, we can get whatever is going on to calm down. And like you said, sometimes the cultures never grow out anything, but they seem to be getting better. And so, we call it PID and say, okay, we treated you, goodbye. But it's not a very rewarding thing to treat. I also wonder, at these children's hospitals, I wonder if they have a pediatric adolescent gynecology service, or if it's just, pediatric physicians that are treating them, because I think that would be different in terms of the training that you've had about STI screening and what should all go with it.
Yeah. They say that most of these women, that these adolescents were treated in the emergency room. So I don't know if they who knows? I mean, in our hospital, it seems like every woman who walks into the door gets a gynecology consult, but it's probably not true. But B, also, I mean, I don't know what these hospitals do, especially pediatric hospitals are a different kind of experience. But certainly the training, and I think it's one of the things they address, is that the training of the providers who are treating these adolescents certainly plays into whether they get the appropriate treatment or not. So, I don't know, there's something, I guess, a whole lot about this I want to say. I have more thoughts and feelings than I do statements.
I did think it was interesting how there's the bias for non-Hispanic African Americans and, girls who are not privately insured. So either publicly insured or no insurance in general, were more likely to get screened. So it kind of shows our inherent bias of these are the people that we think are more likely to have a sexually transmitted infection. I thought that was interesting.
Well, we got bias all over the place today.
Right.
Actually, so one of the private physicians who was my colleague for a few years, when she started her practice, they were not routinely doing gonorrhea chlamydia on their prenatal visits. And because they didn't feel they needed to. It was private practice, private insurance. And so she convinced them to start doing that on all the patients, and she was picking up chlamydia left and right.
Wow.
And so it exactly goes into that. It's our bias deceives us. So, any case, I think for me, it was like, okay, remember that we need to check for these other STDs. And, honestly, maybe we're already doing that and I just don't know about it. But at least the next time I see one of these women, I will be more cognizant of testing for other things, especially the younger they are. So I'm going to move on to the last topic then, and that is a New York Times article. It's from July 20th. And it is entitled, Bayer Will Stop Selling the Troubled Essure Birth Control Implants. Now, I wrote this on my the website. For the listeners who didn't hear the last episode, there is a blog up there now where I'm posting some of my thoughts in real time about some of these things. So I kind of covered this already, but I put tons and tons of Essures in. I was an early adopter of it. I was doing it in the office, which was great because women didn't have to have anesthesia. So I love these things, and it was really because it offered women an easy way for contraception, which is something that I know you all know that I feel strongly about. And it didn't require a trip to the OR. It didn't require any time out of work. It didn't require any incisions. And so it was really good, and especially on women who weren't good candidates for any of our traditional forms of birth control. It was nice. And then probably about 3 or 4 years ago, we started to get some reports of these chronic pelvic pain patients. Here and there, we had women requesting to have the Essures taken out. The first time I did that, I was sweating a lot because I thought it was going to be very hard. As it turns out, it's actually much easier than I anticipated. And now I've taken probably a dozen of these things out. And now, of course, we get to the point where there are so many reports of complications and so many lawsuits that Bayer has decided to just stop selling it altogether, probably because they weren't actually selling any. So it makes it easy to stop selling something if you're not actually have any buyers, right? But so you guys kind of both are trained in this window where we went from using it a lot to not using it a lot. So I kind of want to know what your perceptions of the Essure are, especially Jillian, being a different institution. Did you use it a lot? Did you like it?
Yeah, I mean, I think, like you said, in the appropriate candidate, it was great. Someone who has a history of a lot of abdominal surgeries, but she doesn't want kids anymore. Maybe she's super obese and I don't really want to do a laparoscopic surgery on her. I loved the Essure. I thought it was great. And in the IVF world, if someone has hydrosalpinx and they need either a salpingectomy or Essure coils prior to undergoing IVF, doing Essure coils was kind of a simple, easy solution. So I'm kind of bummed that it's off the market. I understand it had, a lot of negative press, but if you counseled appropriately and got like a good informed consent, I still thought there was a place for it. So I'm kind of bummed it's gone.
Yeah, when the article mentioned, and I think one of my attendants actually mentioned it too, that the Essure initially in April limited the sales to medical offices and practices that agreed to fully inform women about the product's risk. I found that a little surprising because I felt when people are undergoing this procedure, they should be kind of told about the risks. So I'm not sure, were people getting there without actually knowing what some of the risks are? Because when I was consenting them, like I told them, we could perforate the uterus, you might have some pain. And I'm not sure exactly what the other risks that they were talking about. Is there additional risks that I didn't know about when I was consenting them? But I think I only placed 2 in my training so far. I only did 2 as an intern, and then we kind of stopped doing it in second year. And that's when we started kind of telling people, people were kind of going away from it, hearing some of the press. So I took out a lot more in third year. I think I took out more Essures and putting them in. So I don't have too much exposure to it, but in my mind, I was like, is there additional risks I don't know about? And Bayer keeps on saying that it's not a dangerous product. We're just stopping selling it because, kind of like Dr. Chappelle said, we just don't have anyone buying them anymore. The sales are going down. But I agree that I kind of found it fun putting them in the patients who really, really wanted this, sterilization, and they had no other options other than that. So,
yeah, I mean, having that as a tool in our tool bag is sad that we're losing that, because there really isn't a replacement for those exact women that Jillian was talking about. We don't have that. I also found it funny that they said they would only sell to people who did a good informed consent, and I was like, well, shouldn't everyone do a good
that was our reaction.
Consent?
I was like, wait, and how are you going to distinguish who's giving the really good informed consents versus those who are not? Like,
Right. Well, no, I promise. I promise I'm going to do a good informed consent. You can sell it to me. Pinky swear. The other thing I mentioned in my blog post about this is more fundamental to how things get approved in this country. We have a very fundamentally different approval process than Europe in particular, but other countries in general. And the FDA basically can't win either way they go. So if they approve something too slowly, then they get accused of, hampering innovation, and patients don't have access to the latest medical care, and they can go to Europe and get whatever it is. But then if they do something like this, where they didn't really wait for the long-term data, they had about 5 years worth of data before they approved it, because I think it started in 2002, if I recall correctly, and then they approved it in 2007 or 2008. So they didn't wait for 10 or 15 years worth of data before they approved it. Now we get in situations like this where there actually are complications. Now, what are the actual rate of complications per device put in? I'm not sure anyone really knows that yet. But there's certainly a much higher rate of complications than anyone's comfortable with. And so they end up in a situation now where they approve something too early. So, what does the FDA do? What do we want out of our regulatory body? Do we want to be 100% protected, or do we want to make things that are reasonably safe and have access to them sooner? And I don't know. That's a hard question for us in the United States.
Now, what happened? Wasn't there some other hysteroscopic sterilization device, the Adiana?
I'm not familiar with that.
I have to look into it. It came off the market, but I'll have to look into why.
I actually see that right now. Real time follow up here. Adiana was approved in 2009. Looks like it was relatively similar. I'm not sure when it was taken off.
Does it say? What?
Doesn't say. But yeah, I actually never heard of that before.
I never heard of that either.
And then the last part of this story that's interesting, and it came out a couple of days after this New York Times paper article, was about the practices of Bayer selling this, where they were giving all these physicians kickbacks in order to put them in and to market them and to go out in the community and espouse the benefits of the Essure. And that again goes into this, as doctors, what is our job? How do we, I personally feel like I never take any drug samples. I never take a dinner. That's just me. Like I can't do that because I feel like it's a road down temptation to be compromised, and I can't do it. It helps that at Stony Brook, probably 2009, they basically forbade any reps from coming to the hospital and giving the hospital anything. You could have a dinner at an outside restaurant and have people go, but you could never bring any food or gifts or anything into the hospital. And so as a resident, we basically stopped being exposed to any of that stuff. It was actually funny when I went to private practice. I was really annoyed every time the rep would come by and they'd be like, "Oh, I brought these cookies and let me just talk to you for 5 minutes about whatever." I'm like, no, I'm busy. Yeah. Like I'm seeing patients. Like, Like, leave your literature. I'll read it, and if I think it's worth talking, I'll call you. Like, I don't get it. But we do have this market in the U.S. for doctors to pick up some extra money by going out and talking about whatever the product may be. And I've been to some of these drug dinners over my life, and I don't know. You would hope that most people wouldn't go out and sell a product they didn't believe in. But I also know human beings enough to know that, we all have a price as far as whatever that may be, right? So I don't know. That whole part of this bothers me as well, although I'm not surprised because I think all the drug companies do it.
Yeah, I've seen some of those physicians have to post, what they earn from these drug company lectures. And sometimes it's like half their salaries. It's very lucrative.
Yeah. And I don't know. You really can't. I mean, doctors make enough money compared to the rest of the society. We make enough money. Now, we also have more debt than most people do, and there's all that kind of stuff. But we really make enough money. So I was going to say that, with declining reimbursements and that kind of stuff, maybe you could see people trying to pick up some money somewhere else. But really, I can't even say that and get behind that. That's just BS. So I don't know. There's a whole lot of angles to this that are not so good. I'm with Jillian a little bit. I wish we had something that was like the Essure that didn't have these issues with it, because there are women who just really benefited from this procedure. So it's sad to lose it.
Yeah.
All right. Well, I think that was 3 topics. I think we hit them well. If any of you listeners have any feedback, and I can imagine that some of you might have some strong opinions about, I don't know, I'll guess one of the topics we talked about tonight, then you can certainly get back to us at feedback@obgyn.fm. Also, if you go to that website, there is a link up there to join the Slack. We've had definitely a few people join over the last couple of weeks. Very excited about that. Starting to get people a little more involved and make a community that I'm hoping that we can all use to discuss topics like sexism and OBGYN and really make it a place where we can talk about those things, and maybe even salary or whatever else we want to talk about. You guys can make it whatever you need it to be. So please go there, sign up. And if you do, I'll see you there in the Slack. And otherwise, thank you all for listening. Thank you, Dr. Kurtz, for joining us.
Thanks. That was fun.
And thank you, Dr. Kim, for joining us as well. It's always good to have you here.
Yep, glad to be back.
And thank you all for listening, and we'll see you back soon.